I want to tell you about the day I almost got it wrong. 15 years into practice, and I nearly signed off on an Alzheimer's diagnosis for a woman who did not have Alzheimer's at all. Her son sat across from me and said she had stopped recognizing her own kitchen, stopped remembering his name some mornings, stopped finishing her sentences halfway through. I looked at her chart. I looked at her age. And for about 10 minutes, I believed the story everyone believes. Then I looked at her medication list, and what I found surprised me. It was not one dramatic pill. It was three ordinary ones stacked quietly on top of each other for years, each one blocking the same brain chemical her memory depended on. We adjusted two of them. 6 weeks later, she was back in that kitchen making dinner, asking her son why everyone had been so worried. That was not a miracle. That was a mistake, almost being caught in time. I am Dr. William, and this is not a video where I stand here and tell you 9 medications are quietly destroying your brain. It is the opposite. Some of what you have heard on videos exactly like this one is wrong, and some of it came from doctors like me who believed it too before the newer research forced us to look again. Today, I am walking you through what the evidence actually shows, medication by medication, including the ones I got wrong myself. Stay to the middle because two of the drugs you were warned about the loudest may not deserve that warning at all. Before I show you that woman's medication list, you need to understand the one brain chemical this entire video is built around. It is called acetylcholine. Think of it as the messenger your brain uses to lay down a new memory and hold your attention through the day. Your hippocampus. The small structure that files new memories away runs almost entirely on it. As you age, your brain makes less of it and leans harder on every bit that is left. So when a medication blocks acetylcholine even a little, an older brain feels it far more than a younger one does. Doctors have known this mechanism for decades. What we got wrong was the scale of it. What changed my mind is a 2025 review published in Molecular Psychiatry. Researchers pulled together 68 separate meta-analyses covering 11 categories of medication, searching every major database back to its origin. It's the closest thing we have to a full picture, and that picture doesn't look like a simple list of 9 villains. Some of what gets prescribed is genuinely risky, and I'll walk you through the evidence for that. Some of what got blamed for years turns out to be innocent once you control for how the studies were designed. And underneath both of those, there's a third problem that has nothing to do with any single pill. It lives in the gap between 4 different doctors, each handing a patient one reasonable prescription, with nobody ever seeing the full list together. We'll go through them in that order, medication by medication, starting small, moving into a couple that were cleared when almost nobody was watching, and finishing with the one I don't think the healthcare system has fully owned up to yet. Before we go further, tell me in the comments what medications you or someone you love takes every day and how old that person is. I read every one of them, and I mean that literally because for 15 years I was the doctor writing some of these same prescriptions. This is not me pointing a finger at an industry from the outside. This is me showing you my own work and where it needed correcting. Let's start with the mistake I find easiest to forgive because I made it myself more times than I can count. It is believing something is safe simply because it sits on an open shelf instead of behind a pharmacist's counter. The medication is diphenhydramine. You know it as Benadryl. The little pink pill people reach for to fall asleep to calm an allergy or to take the edge off a cold. It costs a few dollars. Nobody asks your age before selling it to you. And for years, that is exactly how I talked about it with my own patients. Take it if you need it. It is over the counter. It is fine. The part I underweighted is this diphenhydramine is a strong anticholinergic. It blocks acetylcholine aggressively and it crosses into the brain with almost no resistance landing directly on the hippocampus. A 2019 study in JAMA Internal Medicine, led by Carol Copeland, followed a nested case control group pulled from an English primary care database, 58,769 people diagnosed with dementia, and 225,574 matched controls, all 55 or older. The researchers tracked total standardized anticholinergic dose over 1 to 11 years before diagnosis. At the lowest exposure level, the risk increase was barely there, an odds ratio of 1.06. At the highest cumulative exposure, it climbed to 1.49. It's a slope, not a spike, and the longer and heavier the use, the steeper it gets. That's the pattern you want to see if you're trying to tell the difference between coincidence and a real signal. I'll say plainly what this is and what it isn't. It's an association backed by a dose-response pattern consistent with what other anticholinergic cohort studies have shown. That's about as strong as observational medicine gets, but it stops short of a courtroom conviction. If you take a nightly antihistamine for sleep, or anything labeled PM nighttime or allergy relief, that label is very often diphenhydramine wearing a different name. Second-generation antihistamines like loratadine don't cross into the brain the same way and are considered far safer for long-term use. Bring that up with your doctor. Don't stop anything tonight on your own. The next one is where I actually owe you an apology because I have watched other doctors present it with total confidence in both directions and neither version was honest. Proton pump inhibitors. Omeprazole sold as Prilosec. Esomeprazole sold as Nexium. Used for heartburn and reflux often for years because the moment people stop the burning comes back and it feels like the drug was the only thing holding the line. Some video like this one has probably already told you PPIs cause dementia. The actual evidence is messier than either side wants to admit. A Mendelian randomization study, a genetic method designed specifically to get closer to causation than a standard observational study, can found that lansoprazole may raise the risk of Alzheimer's disease, and separately that lansoprazole and pantoprazole may raise the risk of vascular dementia specifically. But a separate updated meta-analysis pooling over 642,000 people found no overall increased risk of dementia or Alzheimer's disease from PPI use at all. Two credible methods, two different answers depending on which PPI and which dementia subtype you are even asking about. There isn't a clean verdict here yet, and I won't pretend otherwise. If you take a PPI every day, skip the question, "Is this destroying my brain?" and ask instead whether you're on the lowest dose for the shortest time this condition actually requires, and whether a gentler option like an H2 blocker is worth trying first. Anyone who tells you with total certainty that PPIs cause dementia is further along in that sentence than the research currently allows. The next two mistakes are the hardest for me to talk about because they're mistakes of conviction, not ignorance. I warned patients about these medications with real confidence, using the studies available at the time, and newer research has walked a large part of that confidence back. The first is benzodiazepines. Lorazepam sold as Ativan, diazepam sold as Valium, alprazolam sold as Xanax. For years, the story doctors told myself included went like this. Older studies showed a clear association between long-term benzodiazepine use and dementia. The mechanism made sense: sedation slowed processing chronic suppression of an already aging brain. I told patients to taper off these medications specifically because I was worried about their long-term memory. Some of that advice was good for other reasons. Some of it was built on shakier ground than I let on. What changed is the quality of the follow-up research. Newer studies designed specifically to control for the biases that plague this kind of research have not confirmed a causal relationship. One analysis followed veterans and controlled carefully for cumulative anticholinergic exposure, a factor a lot of earlier studies had ignored. It found that veterans with low benzodiazepine exposure had a nearly identical, or in some comparisons, slightly higher risk of developing dementia compared with veterans who had high exposure. Read that again. Less of the drug did not mean less risk. That is not what a causal relationship is supposed to look like. Other research groups have reached a similar conclusion that the results are consistent with no causal effect at all, and that the original positive associations may be an artifact of confounding or of something called protopathic bias, where a medication gets prescribed because early undiagnosed symptoms of the disease are already present. In other words, the anxiety or insomnia that led to the prescription may have been an early sign of the dementia already forming, not the drug causing it afterward. I once pushed a patient to taper off her benzodiazepine faster than I probably should have specifically because I was afraid of what I believed the dementia risk to be. Looking back, that fear may not have been justified by what we know now, and rapid tapering carries its own real danger, rebound anxiety, insomnia, and in some cases, dangerous withdrawal agitation. Don't take this as permission to stay on these medications indefinitely without a second thought either. Sedation slowed, thinking increased fall risk, those acute effects are still well established. What's on shakier ground is the long-term dementia claim I used to repeat with more certainty than the evidence actually supported. The second one is going to surprise people even more because it might be the single most prescribed medication on this entire list. Statins. Simvastatin and atorvastatin sold as Zocor and Lipitor. If you have watched other videos in this exact genre, there is a real chance statins showed up somewhere on their list of medications to fear. That inclusion is out of date now, and a 2025 systematic review and updated meta-analysis published in Alzheimer's and Dementia, Translational Research and Clinical Interventions, pulled together data from more than 7 million patients across 55 observational studies, the largest dataset ever assembled on this question. Statin use was significantly associated with a reduced risk of all-cause dementia and Alzheimer's disease specifically. For vascular dementia, the numbers leaned the same way, but the effect was too small to clear the bar for statistical significance, so I won't claim protection there, only that there's no sign of harm. For the two most common and most feared outcomes, though, the evidence points toward protection. If a video told you to worry about your statin because of your brain, that video is working from an older, thinner body of evidence than what exists today. Statins still carry their own real side effects, same as any medication. But on cognitive harm specifically, the newest and largest evidence we have says the opposite of what got repeated for years, and that should make all of us, myself included, more careful about how confidently we speak next time. Quick pause. If those two corrections just changed how you see something you or a parent has been taking, that is exactly why I made this video, and it is exactly the kind of thing helps put in front of more people who need to hear it before the wrong version reaches them first. While you're down there, tell me which one surprised you more, the benzodiazepines or the statins. I'm reading through those. Where we go next is different and honestly harder to sit with. Everything so far has been about the medications themselves, whether the drug deserved the reputation it got. What comes next is about a reasonable medication getting used the wrong way on the wrong patient for the wrong reason, often because the system around that prescription broke down. That includes a drug almost never given knowingly, and two others you have probably never seen on a list like this at all. Let's start with the medication almost nobody taking it knowingly agreed to take. Antipsychotics. Quetiapine is sold as Seroquel. Risperidone sold as Risperdal. Olanzapine sold as Zyprexa. These were built and approved for serious psychiatric conditions, schizophrenia, bipolar disorder. That is not how most older adults end up on them. In 2005, the FDA issued a black box warning after finding that atypical antipsychotics increased mortality risk in elderly patients with dementia, a relative risk of 1.6 to 1.7 compared with placebo. About 4.5% of treated patients died, compared with about 2.6% on placebo, mostly from cardiovascular events or pneumonia. 3 years later, the same warning was extended to older first-generation antipsychotics, like haloperidol. Separate FDA warnings followed for increased stroke risk with risperidone, and later similar warnings for olanzapine and aripiprazole. The mistake I need to own isn't really about the drug. It's about the reason it gets prescribed. These medications are frequently used off-label not for psychosis, but for agitation, restlessness, sleep disruption, in patients who are simply confused and hard to manage in a busy facility. I have felt that pressure directly. A family exhausted after months of disrupted nights. A care facility with more residents than staff to sit with someone who is agitated at 2 a.m. An antipsychotic is fast, and it works in the sense that it sedates. Whether it is the right tool for that specific job is a completely different question, one that gets asked far less often than it should. The real story here is convenience quietly winning out over necessity, and I have been on the prescribing end of that trade-off more than once. If someone you love is on one of these medications, don't ask the prescribing doctor whether the drug is bad. Ask why it was started, whether it's still necessary or whether it's there, because it made the day easier for someone other than the patient. This next one you have almost certainly never seen on a list like this. Opioids. A study using UK Biobank data followed 197,673 people living with chronic non-cancer pain. Regular opioid users had a 20% higher incident risk of all-cause dementia compared with people not using painkillers, and the risk climbed with the strength of the opioid. Strong opioid use was also linked to smaller hippocampal volume, reduced white matter, and lowered total brain volume on imaging. Separately, research presented at the Alzheimer's Association International Conference in 2023 found that older adults who started opioids after already being diagnosed with dementia faced a risk of death that was 11 times higher in just the first 2 weeks after that first dose. Roughly 1 in 3 died within 180 days compared with dementia patients who never started one. It rarely shows up on lists like this one, and I think that gap is itself a kind of mistake. A mistake in what gets talked about publicly versus what actually shows up in the data. Diphenhydramine gets attention because it's cheap and sitting right there on a drugstore shelf. Opioids carry a different kind of stigma tied to addiction conversations, and that stigma somehow keeps this specific cognitive risk out of the headlines, even though the data doesn't care what conversation it's attached to. If you or someone you love manages chronic pain with opioids long term, that's worth a direct conversation about the lowest effective dose and what non-opioid alternatives exist. Last in this section, and this one is personal. Z drugs. Zolpidem, Zaloplan, Zopiclone. For years, I described these to patients as the safer alternative to benzodiazepines for sleep newer without the baggage. I was repeating what I'd been taught, and it made intuitive sense at the time. A large observational study found that at higher doses, Z drugs carried risks in dementia. Patients' fractures, falls, strokes similar to or greater in magnitude than higher dose benzodiazepines. A separate study out of Taiwan following adults 65 and older found zolpidem use significantly associated with dementia after adjusting for major confounders and adjusted odds ratio around 1.33. Clinical guidance now states plainly that Z drugs should be avoided in people with dementia, and yet they are still prescribed regularly in part because of exactly the reputation I helped spread. I moved patients off benzodiazepines and onto Z drugs and called it progress. The more recent data suggests what I actually did was trade one set of risks for a different set, not swap risk for safety. It's an uncomfortable thing to admit on camera. It's also true. Now we reach the mistake I think is the biggest one, and it is not a medication at all. It is a blind spot built directly into how healthcare is organized. Picture it in practice. A neurologist sees a patient for chronic back pain and prescribes gabapentin. Down the hall or maybe across town, a rheumatologist treats the same patient's joint inflammation with a corticosteroid, and a urologist adds something for bladder symptoms on top of that. Each decision taken alone is defensible. None of those three doctors ever saw what the other two had already written. That's not a hypothetical scenario I'm inventing for effect. It's how most healthcare systems are actually structured. Specialist by specialist, chart by chart, with no single person required to look at the whole list at once. Let's look at what that combination can actually mean. A cohort study matching over 26,000 gabapentin users against 26,000 controls with chronic low back pain found a 29% increased risk of dementia and an 85% increased risk of mild cognitive impairment. Patients with 6 or more prescriptions fared worse, still 40% for dementia, 65% for MCI. The researchers were upfront that this is association, not proof of causation. Corticosteroids tell a different story. About a third of people on long-term corticosteroid therapy show measurable deficits in working memory, attention, and executive function tied to dysregulation of the stress hormone system and reduced hippocampal volume. But here's the part worth holding on to: corticosteroid-related cognitive impairment is one of the few entries on this entire list with strong evidence that it reverses once the medication stops. Add a bladder antimuscarinic on top of both, and you've got 3 separate cognition-affecting signals stacking on the same aging brain, with no prescriber holding the full picture. Large-scale data backs up how real this stacking effect is. UK Biobank research tracking roughly 200,000 participants found that anticholinergic burden was associated with dementia risk across most measurement scales, with the strongest signals concentrated in antidepressants, antiepileptics, and certain diuretics used together. This is the mistake I find hardest to sit with because it isn't about any one doctor acting carelessly. I have been one small piece of exactly this puzzle. I have written a prescription confident it was the right call in isolation, without ever seeing what 3 other doctors had already put in that same patient's medicine cabinet. Nobody in that chain did anything indefensible on its own. The harm, if it exists for a given patient, comes from the sum that nobody was ever assigned to calculate. I want to leave you with something more than a warning, though. A 2024 case report in the British Journal of Clinical Pharmacology described a 76-year-old woman who showed significant cognitive improvement after her doctors reduced and discontinued a strong anticholinergic she'd been on long-term. That's real, and it's hopeful. It's also one case, so let me tell you what the bigger picture looks like. A 2023 Cochrane review went looking for solid trial evidence that deliberately reducing anticholinergic burden improves outcomes, and found only 3 randomized trials of such low certainty that the reviewers said they couldn't confirm or rule out a benefit. And that's true, not just for cognition, but for falls, quality of life, and survival too. A dedicated trial called R2D2 is running right now to answer this properly. We don't have that answer yet. What we have is a strong biological reason to hope one compelling case, and an honest admission that the rigorous proof is still being built. So let's turn this into something you can actually use, starting with the distinction that almost fooled me at the beginning of this video. Delirium and dementia are not the same thing, and mixing them up is where most of this fear gets manufactured. Delirium comes on fast hours or days, fluctuates within the same day, and is usually triggered by something specific: an infection, a new medication, a hospital stay. It is frequently reversible once the cause is treated. Dementia builds slowly over months and years and does not resolve the same way. The woman I told you about at the start had every symptom families associate with dementia. What she actually had was medication-induced delirium layered on top of an aging brain that had very little acetylcholine left to spare. Two tools to actually use this week. First, a free resource called the ACB calculator at acbcalc.com. You can look up any medication you or a family member takes and see its anticholinergic burden score. 1 point for possible, 2 or 3 for definite. A total score of 3 or higher is considered clinically significant. It takes 5 minutes and costs nothing. Second, something geriatricians call a brown bag medication review. Once a year, take every single bottle you have prescription over the counter, supplements all of it into one bag and bring it to your doctor or pharmacist to go through together, line by line. It catches duplicates, unnecessary doses, and dangerous combinations that no single specialist would ever see on their own. One more thing before we close. Do not stop any of these medications on your own, especially benzodiazepines or Z drugs, where sudden withdrawal can be genuinely dangerous. Everything here is a starting point for a conversation with the person managing your care, not a substitute for one. Remember that woman from the beginning back in her kitchen making dinner. This video was never about scaring you away from medication. It was about the fact that even a doctor with 15 years behind him needs to keep asking whether what he believes is still true. You are allowed to ask that question too. Tell me in the comments which of these 9 you are taking, and tell me you will book that medication review this week. Someone reading your comment may need to hear it. And next time I am tackling a piece of misinformation, just as widespread as this one about what your blood pressure numbers are actually telling you. I am Dr. William. Stay sharp, and I will see you there.